Welcome to the Human Factors and Ergonomics Hub, a series of educational podcasts that showcase the connection between human capabilities and good work design, brought to you by the Human Factors and Ergonomics Society of Australia.
I'm David Caple, and it's my pleasure to introduce today Professor Pascale Carayon to the HFESA podcast. And Professor Carayon is one of our eminent leaders at an international level who is currently living in France, having spent a lot of her academic career in the US. So, Pascale, before we start talking about that career, let's talk a little bit about you and your personal background. How did you get involved in this profession, and where were you at the time?
Well, thank you very much, David, for organizing the podcast. I was trained as an engineer in France at the École Centrale de Paris. And after getting that engineering degree, decided to go to the US for a PhD in HFE. I ended up at the University of Wisconsin in Madison, as I was always interested in more the organizational system aspects of people interacting with technologies and their jobs. My advisor was Mike Smith, who unfortunately passed away last year. And that's really how I became connected to HFE with Mike, and again, learning a lot about the different domains of HFE, in particular the organizational domain. And I got hooked then as a PhD student.
And did you stay living in Wisconsin, or did you come back to France, or how did you go after the PhD?
So actually I ended up spending 1 year as a visiting professor, and then was hired by my department, the Department of Industrial. At that time it was Industrial Engineering. It became later Industrial and Systems Engineering. So I was hired as an assistant professor, then got promoted to associate professor with tenure a few years later. And then between 1995 and 1999, went back to France to work at the École des Mines in Nancy, in the eastern part of France. And then in 1999, went back to the US. This is where I finished my academic career back to the University of Wisconsin in Madison.
So when you went back there, what were the areas that you were mainly focused on? Because a lot of your publications have been in the patient safety and healthcare sector. Was that going as an area for you in that early 2000 period?
So actually, the healthcare and patient safety domain is something that I really started investing when I went back to the US after spending 4 years in France. But I have to tell you a little story, David. When I was a PhD student, Mike Smith was really keen about having us, the PhD student, understand what it was like, what the work environment was like. So there were he had 5 PhD students at that time. That was in his early phase of being a faculty at the University of Wisconsin. And he told us, to each of us, go spend a few hours in a workplace. And I ended up being in the intensive care unit at the University of Wisconsin Hospital. And so imagine a 20-plus year young woman, French, with a funny accent, being sent to an intensive care unit. And I was there. I was just fascinated. Of course, they gave me a chair and told me to sit in a little corner. And there were all kinds of noise, all kinds of things happening. Some of it was pretty scary. I mean, people who are in intensive care units are between life and death. There were a lot of things to observe and to try to understand in terms of communication, coordination, physical aspects of their jobs, psychosocial aspects, and so on. And so after about a couple of hours of doing observations and taking some notes, I ran back to the department and rushed to the office of Mike Smith. And I was really excited to tell him about everything that I had seen and about job design and organizational coordination and so on. And the first thing that Mike said is, Pascale, did you wash your hands? He was very keen about infection control and prevention. And so I had to make sure to reassure him that I had washed my hands indeed. And then I was allowed to share my observations. So that was my very first experience with healthcare. But the research program started really back in 1999 and the early 2000s when I went back to Wisconsin, and the whole patient safety issue came about with reports by the Institute of Medicine that talked about a lot of people dying of preventable medical errors in hospitals in the US, and then a lot of research funding being put into these areas. And so that's really when I started getting into the healthcare and patient safety domain, so in the early 2000s.
So that's 25 years ago now. And during that period of time, I know you've been a leader in this area. Your name seems to be in many conference proceedings and keynotes. And have you been networking much outside of the US in this space, or has a lot of your research been based, well, I know you're not there now, but in Wisconsin?
So a lot of our research in healthcare is in the US because of the kind of research that we do. You know, we need access, we need to talk to people, we need observations. And so the healthcare facilities that we work with were in Madison, in different places in Wisconsin, but also in different healthcare around the US. So the research itself, we did it in healthcare organizations around the US.
I was just going to ask you a little bit about how did the Systems Engineering Initiative for Patient Safety, SEIPS, which is such a fantastic methodology. I read it so often in journal articles that people around the world are using. Tell us a little bit about how that came to be and what is it?
Yeah. So when the different reports from the national academies in the US came about, like I said, there was a lot of research funding put into patient safety, including a really unique opportunity for people who had not invested a lot in patient safety to become active into that area. So the Agency for Healthcare Research and Quality, AHRQ, had a call for proposal to develop to create developmental centers in patient safety, and those developmental centers, I think there was funding for 18 or 19 of them, not a lot of funding, but just to get started. And our group at the University of Wisconsin was actually the only one located in engineering that was funded as a developmental center. But from the very beginning, I mean, I'm an engineer, so I did my career in engineering, particularly industrial and systems engineering. But from the very beginning, it was a highly collaborative enterprise, working with people in, of course, other domains of engineering, but with physicians, with nurses, with pharmacists, with hospitals. And so then we created that network of researchers and practitioners. That was another key dimension of our program. And then a bunch of us started through that developmental center grant, started talking about what our framework would be like to think about patient safety. And that's when we created the SIPS model. It was a paper that was published in 2006. And I always point out, it's when you look at the list of authors, there's a nurse, there's someone specialized in informatics, someone with a background in infection control and prevention. There's a couple of engineers, and so it's a highly diverse group of disciplines that were involved in this paper. And then that's how SIPS started, with that publication, and then that became the first. I call it the SIPS family now, because SIPS has kind of grown into different models, and that was the seed. The paper, the model, with the collaborative environment that we created, that allowed it to bloom and have an impact over the years.
Wonderful. And tell us a bit about some of the areas of application of SIPS. So I know you've done some work with vulnerable patients and ICUs, where you started and you remembered to wash your hands. So tell us a bit about some of those application areas.
So some of it was opportunistic, is people who had a problem and were interested in working with us and trying something different. So for many years, I worked in intensive care units. Ken Wood is an ICU physician that I worked with for many years. And then we expanded. We were. I shouldn't say it didn't matter what area we worked in, because we always identify a problem in that particular patient safety problem in that particular area. And of course, people who work in patients who are in environments such as ICUs are very vulnerable to many patient safety risks, and in particular, patients that have fewer resources, whether they're cognitive or psychological resources, such as elderly patients and children. So we ended up working in a really a large variety of domains, where we found key collaborators and places that had major safety issues. In the last few years, we worked quite a lot in the emergency department, which is also a really interesting environment. This is when someone has an acute problem or an accident, this is the first place that they go to. So it's kind of the entry to many other domains of healthcare. People don't stay very long in ED, sometimes too long, but they should not. So there's kind of a concentrated process that is very important, very critical, where many decisions have to be made, sometimes with not a lot of information. So from an HFE perspective, that is a very challenging environment. And so that's where a lot of our research has been in the last few years, in particular, looking at elderly patients that arrive to the emergency department and then go to the hospital, get admitted to the hospital, go home, or go to other places.
And you mentioned earlier that you worked in this multidisciplinary team to develop a framework of SIPS. But do you want to just tell us a little bit about the methodology of, you're in the emergency department? You mentioned initially you did a lot of observation when you were a postgrad student, but How does, for those not familiar with this product, if you could call it that, what are the key elements to it?
So SIPS is about thinking in system, and it's a thinking in system from an HFE perspective. So the person is always at the center. So we think about the person performing different tasks using tools and technologies, and all of that happening in a physical and an organizational environment. And of course, following the IEA definition of HFE, we're interested in different outcomes, performance, safety, but safety for patients, also safety for workers. So that system thinking, that framework, then is one that's really kind of printed in our brain, and then that's what we use to understand a particular care process using all kinds of different methods. It can be observations, interviews, focus groups, surveys. Sometimes we use video recording and show those video recording to patients or healthcare workers. But we always do it we always collect the data in thinking about the system. Who are the people? What are they doing? What is the physical environment like? What are the issues related to coordination and communication? And so then that data get collected. Very often when we understand a care process, it's never just one data collection method. It could be observation and interviews, or interviews and surveys and observations. So we're very multi-method type of research. And then all of that data get collected, and then we put it back into that framework, into that systems model that then allow us to make sure that we understand the entire system, all of these 5 elements: the person, the task, the tools, the physical environment, the organization. And then we put those data into that framework, and then that allows us to identify pluses, minuses, barriers, and facilitators. And then on top of that, we put a layer of the term that I like using is human-centered design. So, a collaborative, participatory approach that allows stakeholders to come together to look at the data and to figure out what are the main issues and a solution, and then to implement it and evaluate it. So SIPS is kind of in the background, but it's also, the SIPS model is in the background of what we do. But it's always there, it's whether it's in collecting data, analyzing data, in our participatory human-centered design projects, it's always there. We show it to people. We have them understand what it's like. When we come up with a solution, it's there. When we evaluate the solution, it's there. So the SIPS model is there at all phases of the project, from data collection all the way to implementation and evaluation.
You mentioned about the people being the center as starting point. I recall a conference I was with you in France on healthcare. What I was surprised about, there were sort of 2 groups of people. One of them were the staff, the nurses, the doctors, and the impact on the systems on them. But the other were the patients themselves, with the negative outcomes of their experience in the hospital setting. I didn't realise that there was such an organised patient advocate group. Tell us a little bit about how they participate in these projects.
Yeah, so the whole patient-centered care movement has grown quite a lot, and I think this is really great, and that has led on the HFE and SIPS side to quite a lot of our junior researchers, and now they're getting more senior to develop programs around what they call patient ergonomics. I'm thinking of Rich Holden, Rupa Valdez, Nicole Werner, and others. But I think the thinking about the system from the people inside the system and not just the workers but the patients has been really great. So let me just give you an example. That recent project looking at elderly patients who go to the emergency department. And our goal was to figure out how to understand the whole process in the ED, but in particular, what happens at the end when the patient leaves the ED. Very often they leave and then, wow, I'm not sure what's happening to me, what I should do. And so that was that discharge, what we call discharge, of leaving the emergency department and going home. That's the particular focus that we had. In that project, we put together an interdisciplinary team that included the spouse of a patient. She had accompanied her husband, I think, a huge number, like 10 times or 12 times in a period of a year and a half. So unfortunately, Paula had a lot of experience in interacting with the ED. So she was a full member of that design team that we put together to come up with a solution. And then David, you've done a lot of participatory projects where you get into a situation where you need to figure out how to bring all of these different perspectives together, sometimes manage diverse opinions, sometimes manage conflicts, but really create a common ground. And so we've done quite a lot of work in those participatory processes to make sure that the patient's voice is there through direct participation. So Paula was a member of that design team and had a lot of say in what we were doing, how to understand the data, the solution, the implementation, and so on. But of course, we also use indirect participation through for instance, in that case, observations of patients and survey. We had a couple of our graduate students who spent almost 200 hours in the emergency department following about 20 patients from the time that they arrive in the ED until they leave the ED. And they stayed with them. So a lot of really rich understanding of what it is like to be an elderly patient in the emergency department. So there are all kinds of different ways that we get patients connected to our project and involved not what I call, genuine participation. It's really meaningful participation. It's not when I ask for your opinion and then you go, but I ask for your opinion and I want you involved in making decisions about what we're going to do.
And do you think over this 25 years or so that has matured to the point of active participation? And where do you see the next step going in this methodology and the application where you're working?
Yeah, so the answer is yes. So I mentioned the group of people who have really done a lot to develop the conceptual and methodological aspects of patient ergonomics and seeps from the perspective of patients. And when you start looking at that, then you got to step back and think of actually a much bigger system, because it's not just what happens in your interaction with healthcare. I haven't mentioned primary care, which is of course also important, but it's all of these things that happen in between. How do I do to schedule an appointment with X? What is it that I do as a person to care for my health? So I see that that evolution of understanding not just patient safety, but what I've called healthcare safety. And in the future, it might be just health safety in general, of looking at a bigger chunk of the journey that people go through their life, not just a journey, a patient journey. And, we've written a lot about patient journey and lack of coordination between different healthcare entities, but the health journey of understanding, again, the whole experience of people in between their interactions with the healthcare system. And that is I think, a fascinating area that has really a lot of major implications for HFE, because those are much bigger system. There are many more actors, more opportunities for conflict and divergence, and a bigger time frame. And there are questions, basic questions as an HFE person. Where do I go and observe that health journey? And so, going to patients' home, to people's home, and all kinds of really interesting issues from a methodological perspective, and potentially huge impact on the health of the society and health of population.
I can feel your excitement about how this is evolving into a much broader application area. And you talked about the students that you had working with you. Tell us a little bit about your role as a mentor and a supervisor, and what have you learned from that?
Well, I've had the chance to work with many different students and trainees in engineering, and of course in HFE, as well as in different health professions. I've been a mentor for physicians, nurses, pharmacists, and so that has been quite interesting. And of course, my role being one of mentoring and teaching, but also in the process, learning a lot. It's always that mentor-mentee relationship it has to be a two-way relationship. Otherwise, it doesn't work. So I've had the chance of being involved in those mentor-mentee relationships in all kinds of different disciplines, and a lot of them have been women. Have been young women. So that has been really the highlight of my of my career as an educator, of helping a lot of young women to develop and gain confidence and play amazing roles in HFE as well as in patient safety in general. So that's why I really insist. I'm glad we're talking to each other today, David, but I think about the whole group of people that I have interacted with and that are taking on new projects and new ideas and new challenges, and when I see that, I'm happy and I'm proud of them.
And just as an example of that, Pascale, we met in Bordeaux at the ODAM conference a couple of years ago. My observation of you was it was like bees to a honeypot. It was so wonderful to see these young women who were all wanting to take a piece of your time to share what they had done and the research that they were doing. And it must make you feel very proud to see their journey that you've influenced along the way.
Yes, and what they're going to be doing, and then the people they're going to train, or the people they are training, the young men and women that they are training in HFE, in patient safety or health safety in general, so that that is important to keeping that SIPS family growing and having more and more impact in the long run.
Pascale, just for the record, for the listeners, I'll just repeat some of the data. You've published 203 articles, you've authored 5 books, 71 book chapters, 253 conference papers, 182 keynote presentations and invited talks, and it just goes on. I mean, well done to you. It's been such a long journey, but I just want to talk to you about your role as the Editor-in-Chief of Applied Ergonomics. I'm not sure exactly how many years you were in that role, but I'm just interested, what have you observed in the maturity of what people are seeking to publish about? Has there been any trends or any particular issues that you'd like to mention through published research?
So I think a couple that I can mention, and I had a chance of working with John Wilson for many years until he unfortunately passed away too early. And applied ergonomics, from the get-go was really applied. And sometimes you remember, David, we had conversation with Pierre Falzon about why do you call it applied, and John Wilson was also involved. Why do you call it applied ergonomics? Ergonomics is applied. Well, not everybody thinks that way. So that's a key characteristic that I've kept as I was involved with applied ergonomics as editor-in-chief, and of course more and more papers submitted and published related to healthcare and patient safety. But also the other thing I'd like to mention is papers about methods. Sometimes those papers are really difficult to publish. Is a particular method of how to collect data or how to analyze data. Very often, method is just in that method section of the paper, and it's like a couple of paragraphs, and this is it. But there's actually a lot of value in writing a whole paper on an innovative method and evaluating the method. And so that's one thing that I was keen of doing, and leaving a place, a spot for that type of research. So that I think those were the two main things: the healthcare patient safety, and then papers on methods, on HFE methods.
And I know you're on the editorial board of a few other journals, including Work and Stress and Behaviour and Information Technology. How do you juggle your time with the different applications of HFE?
Yeah, that's a good point. So the ITP, so for instance, behavior and information technology that I was involved in for quite a few years, was really related to the IT aspect of my research in healthcare, but also years ago in the early phase of my career, looking at IT applications, in particular in the office and administrative environment. So I've always had an interest in IT, in all kinds of different domains.
And I can't let this podcast go without talking about our joint involvement in the International Ergonomics Association. And Pascale and I used to sit together at some of the meetings, and I must admit I really enjoyed our time together. And Pascale was the Secretary General of the IAA, and you've continued your involvement really for decades. So tell us a little bit about what you're doing now through the IAA with the World Health Organization in Geneva.
Yeah, so before I do that, David, I have to recognize how important that time was when you and I were in the executive committee, and you were the chief, you were the leader of the team, and that was really important. And that was actually also at that time when the healthcare patient safety domain became to really bloom and take an important role in the international community. And that's how the conferences, the HEPS conferences, the Healthcare Systems Ergonomics and Patient Safety conferences then became IEA conferences and are still going on today. They're really important conferences for the international HFE community. And so I've continued my involvement at the international level. And that most recent project with the World Health Organization has been really dedicated to more dissemination of HFE ideas and how can we figure out how to explain to the international healthcare community what HFE means and what does that systems thinking in HFE means. So we've been working with the patient safety group at WHO. A number of people on the IEA side have been involved: Kathy Mosier, Michelle Robertson, SQ, Sue Hicknet, Maya Kamelas, and I'm probably forgetting quite a few people. And we're getting close to our goal of publishing a document that explains that HFE systems thinking approach to patient safety. Of course, a lot being based on the SIPS model. But as you know, the document is only one first step. There is a lot that would need to be done later on to create a dynamic dissemination process and learning, because this is not really intuitive for many people in healthcare to think in system. They very often focus on one aspect of the system, and we want them to understand the entire system before jumping into solutions. So that's where we are with our WHO project.
Hopefully we can find out when it's published. And I know for our listeners that Wendy McDonald from La Trobe University is involved in a similar project on musculoskeletal disorders with the WHO. So it's terrific, this collaboration that's happening at an international level. Pascale, before we finish, I just want to make sure the listeners are aware that in 2024, Pascale was admitted to the National Academy of Engineering for application of human factors engineering to healthcare systems to improve patient safety. So firstly, congratulations. But for those that are not aware, tell us a little bit about what this honour is about. What is the National Academy for Engineering?
Thank you, David. That was indeed quite an honor to be recognized by the entire engineering community for research that I've done in human factors and patient safety. There are 3 national academies in the US: the National Academy of Engineering, the National Academy of Medicine, and the National Academy of Sciences. In the National Academy of Engineering, you find a few HFE leaders, and I'm probably going to forget some of them, but hopefully they don't get mad at me. But I mentioned Bill Maras, Gabriel Salvandi, Don Chaffin, Kay Staney, Nadine Sauter, Tom Sheridan. And so those are members of the National Academy of Engineering. So there are not that many HFE people in the National Academy of Engineering. And so that was really a great recognition for me as an engineer who's also somebody who think in system and look at people within the system. It's kind of an unusual combination for an engineer. So being recognized for research in that area by my peers was quite humbling.
And one of the good things about that is that this academy is recognizing HFE as as a discipline. And I think we all get a spin-off from your recognition that what we do is recognized and appreciated at that level. So Well done, and thank you. So before we finish, Pascale, what's life looking like for you now? You've moved on from living in the US. You're now back living in France. Is that right?
Well, I've been lucky. I've been able to develop a great career and have amazing opportunities in the US and resources to develop my research. And I'm very lucky to live in France, a beautiful country. Kinds of also amazing resources. My husband Peter Hunaker and I are living close to our Dutch family and our French family, so that is also very precious at this point in time, and have developed a really great group of friends, French friends, but also people coming from the UK, from the US, from Germany, Belgium, all kinds of different countries. So we kind of created our own little international network in our part of France, David. This is important to us.
And I can understand why. So look out, you might get a few Australians coming after this podcast. Yes. So look, thank you, Pascale. It's been wonderful talking to you again. And best wishes to Peter. And we hopefully might see you in London next year at the International Ergonomics Association Congress. But if not, I'm sure we'll be listening to some of your students who will continue what you have led. And so thank you very much, Pascale.
Thanks for joining us at the Human Factors and Ergonomics Hub, brought to you by the Human Factors and Ergonomics Society of Australia, where human-centred design really matters. If you like this podcast, make us your favourite in your podcast app. We look forward to chatting with you next time.